So thank you
Ready?
very much indeed, Maria. Thank you, Katrina, for the kind invitation. And thank you also, Claudia, for your really touching presentation. And I want to share with you what has been our experience with COVID-19. So the virus was first confirmed to have spread to Italy at the end of January when two Chinese tourists in Rome were tested positive for the virus. 1 week later, an Italian man repatriated back to Italy from China was hospitalized and confirmed as the third case in Italy, and by the beginning of March, the virus has spread to all regions of Italy. And the 8th of March, the president of the Italian government decided to lock down the country. The Lombardy outbreak came to light when a 38-year Italian man was positive in Codogno, not far from Milano, and then the following days the spread to all the region of Lombardy was really impressive, and we had to manage, as in Spain, a number of patients with very severe cases of COVID-19 pneumonia. I want to share with you some data from our experience. You can hear me well?
Yes, yes, Sergio,
Okay.
it's perfect.
Okay, thank you. So due to the necessity of respiratory intensive care unit, the lung unit ward of my hospital where I work was converted in a COVID-19 dedicated intensive respiratory care unit since the 9th of March. So we had patients there admitted as semi-intensive intermediate care unit, like the one who spoke about just a few minutes ago, Claudia, but also patient intubated. So we had bed helmet CPAP and 6 beds equipped to be for intensive care, and we manage patient with intensivist with shared competence and strength, allowing to manage all the degree of severity of patient. And obviously a regional network collected patients from everywhere in the region, and when you had a bed free, immediately you received patient also from other hospitals in the country. One week later, another COVID-19 ward was opened in a hospital in order to receive patients less severe, but needed to be admitted. And their doctor with different specialties from gastroenterologist, ophthalmologist, and so on, work together, supported by pulmonologists and intensivists who lead the team. Collaboration and availability to learn a new skill has allowed this new word to work. And I think finally the level of medical assistant was quite high. So from the 3rd of March to the end of April, we admitted 260 patients with a prevalence of male. The mean year-old was 72, and with a wide range, as you can see. If we consider all these patients, the mortality was 32%, so very high mortality. If we consider only the 84 patients that was admitted to the pneumological department with intermediate and intensive care unit, these were a little bit younger, 66-year-old, around, always a prevalence of male, and obviously a long stay in the department. The comorbidities, just to say something, most of the patients had systemic hypertension. And as you can see, we have two degrees of severity, and patient with severe pneumonia had a very low PaO2 FeO2 ratio. I don't want to go through all the data. Most patients were treated with helmet. A third of patients were intubated, and 12% of patients had to go to tracheostomy. Most patients were treated with corticosteroids, and at the beginning of our experience, also a certain number of patients were treated with the association of lopinavir, ritonavir, and hydroxychloroquine. Some patients were also treated with tocilizumab. But after the first month, the epidemiology changed a little bit. As you can see, in the second month of it, we admitted very few patients compared to March, and those patients were older, coming from recovery for old patients, and they came also a little bit before compared to the first month of patient. And these patients were less sick compared to the first period of time. No one was intubated. Of these 13 patients, no one needed tracheotomy. And also our management changed a little bit in the treatment, in the pharmacological treatment. So coming to the last slide, among patients referred to our hospital, a wide range of age has been observed with the prevalence of male. I must mention that unfortunately, also some young patients died. Comorbidities did not affect the severity of the disease, although we have reported a high prevalence of systemic hypertension in all patients. The majority of the patients were admitted to our intensive respiratory care unit during the first month of the pandemic in March. Patients admitted during the first month were younger and presented less comorbidities compared to the average. And moreover, they show a more inflammatory pattern, as suggested by increase of CPR, LDH, interleukin-6, and lymphopenia, which were related to a worse prognosis. Treatment was wide. Only during the first month we used ritonavir, lopinavir associated with hydroxychloroquine. Steroids were used since the end of the first month and seem to be effective in reducing the cytokine storm in this patient and improving survival. I will stop here. Thank you for the attention.